All right, now we're going to talk a little bit about pediatric patients with special healthcare needs.
These children are diverse patients who frequently need pre-hospital emergency assessment and treatment. This higher user group includes, but is not limited to, children born prematurely, have suffered a closed head injury, and or have central nervous system injuries, or have chronic problems of the lungs, brain, or kidneys. Acquired conditions include cerebral palsy or bronchopulmonary dysplasia.
Some children with special healthcare conditions are assisted by or dependent on technology. This is a subgroup of children with special healthcare needs. This group requires devices to survive. Typically, devices include tracheostomy tubes, home ventilators, indwelling central venous lines, feeding tubes, pacemakers, and cerebral spinal fluid shunts.
Today, children with special healthcare needs survive longer and often live at home. As a result, they need emergency medical care more frequently than children without special healthcare needs. In addition, because of their unique baseline status, these children pose unique challenges in field assessment and treatment. So it is important that pre-hospital professionals can recognize common types of patients, incorporate modifications during the assessment, and understand the management of frequent problems.
According to the American Association of Intellectual and Developmental Disabilities, an intellectual disability is defined as a disability that is characterized by significant limitations in both intellectual functioning, reasoning, learning, and problem solving, and adaptive and behavioral functioning, which covers a range of everyday social and practical skills. The term intellectually disabled is also mental retardation. They mean the same thing, yet intellectually disabled is the preferred term.
Mental processes such as judgment, reasoning, memory, and comprehension are cognitive and develop as the children requires knowledge. Therefore, cognitive impairments are often present when there is an alteration of the child's ability to think, reason, learn, and abstract. Several examples include autism spectrum disorder, ASD, attention deficit or hyperactive disorder, ADHD, and intellectual disability, which is a limited mental function in areas such as communication, social skills, and self-care. Physical disabilities may alter the child's mobility or accomplish daily living activities independently.
In addition, medical and traumatic emergencies may occur that may have nothing to do with actual physical impairment. These disabilities include physical conditions such as hearing impairment and visual impairment.
Chronic conditions are conditions that present when the child receives ongoing treatment for an injury or illness. If the child seems healthy, they may be on a maintenance medication or treatments to prevent complications. Examples of chronic conditions include asthma, cancer, post-transplant patients, and congenital heart disease.
Other chronic conditions include bronchopulmonary dysplasia, which is a chronic lung condition that develops in premature infants who require respiratory support after birth. These infants are at risk for deterioration with any respiratory illness. They can have constant wheezing and may require supplemental oxygen at home and may have pulmonary hypertension or decreased pulmonary function. Cerebral palsy is a disorder of movement and tone that results from brain injury during fetal development or at birth. These children may have increased muscle tone, trouble walking, or coordination problems. They may wear orthotics on their legs to assist with ambulation or be in a wheelchair. In addition, they may have intellectual disabilities, but they may or may not have this.
Cystic fibrosis is a congenital disorder that results in lung and digestive disorders due to improper functioning of mucus-producing or endocrine glands. CF results in frequent lung infections and pneumothorax and impaired digestion and absorption of the nutrients, resulting in poor growth.
Down syndrome is a congenital disorder in which a child is born with 3 copies of the X chromosome, called trisomy 21. As a result, they have typical facial features, and they are at risk for congenital heart disease and defects, cerebral spinal injuries due to C-spine abnormalities, and they may also have varying levels of cognitive delays.
Muscular dystrophy is a genetic muscular disorder that results in muscle weakness and wasting. These children are at risk for aspiration and pneumonia.
Spina bifida is a congenital abnormality in which the spine has failed to fuse, resulting in protrusion of the spinal cord and meninges at birth, usually in the lumbar region, but can occur anywhere along the spinal column. While these lesions can be repaired, the children sometimes have hydrocephalus, impaired lower extremity strength and feeling, and bowel and bladder problems.
Sample history and assessment for patients with special health care needs relies heavily on communication with the caregiver. The essential resource for the pre-hospital provider is the child's caregiver. They usually know how to care for the child, particular condition, and understand their equipment. Often, caregivers have forms or cards that outline the child's medical history, medications, general baseline appearance, oxygen saturation, and vital signs.
Keep in mind the amount of stress that caregivers with a child with special needs may be experiencing. Ask the caregivers what therapies or interventions have already been undertaken and respond well with their child in an emergency. If possible, try to transport the child to their medical home facility, the facility they usually go to in a time of emergency, and always follow local protocol.
Ask the caregivers what is usual for the child. Most likely, they will know the child's baseline better than anyone. On these calls, you will trust and rely on the caregiver's opinions and what they think is wrong. In what ways is the child acting differently?
If the child is psychologically stable, take a complete history on scene. Caregivers usually know the child's medical history, health problems, medications, medical devices, and current complaints. They are also aware of the best approach to communicate with their child. The child may be slow to answer questions or unable to talk. Use the patient approach to stable child by talking directly to the child rather than the caregiver if the caregiver states that this is the best approach.
Assessment of children with special needs. Begin evaluation of these children with emergency pediatric assessment techniques adjusted to the child's developmental level rather than the chronological age. Caregivers can usually provide the child's developmental age, weight, and baseline vital signs. As a result, children assisted by technology do not become distracted by their specialized equipment. Care for the child, not the machinery. Caregivers are often extremely helpful in figuring out the baseline status of these children or operating or troubleshooting the equipment. Ask for assistance from the caregiver.
Minor illnesses can be life-threatening for some of these children. An example of this is a child with chronic lung disease that has a cold. These children may have very little reserves and quickly become hypoxic.
Communicate with the child using developmentally appropriate language, gestures, and techniques. If a caregiver is not present, find out if the child has a form or card with information about their medical problem, typical vital signs, medications, and other critical medical data. Look for a bracelet or necklace that might describe the child's condition.
Keep in mind that baseline vital signs for these children may be out of normal range compared to other children the same age. Therefore, standard vital signs may have limited value in assessing these children. Instead, pay more attention to the pediatric assessment triangle and observations from the caregiver.
The PAT is an excellent way to look and listen for signs that help determine the physiological problem and the urgency for treating a child with special healthcare needs. However, because these children often have altered baseline physiologically, there are several limitations and modifications to the PAT.
Although the child's overall appearance reflects the adequacy of oxygenation, ventilation, perfusion, and CNS status, this is a part of the PAT that may differ in most children with special healthcare needs. The underlying medical problem may cause abnormal muscle tone, such as increased tone and spasticity in a child with cerebral palsy, or decreased tone as seen in children with Down syndrome. In addition, there may be reduced interactiveness, which is a common behavioral state in a child with a brain damage or intellectual disability. Look or gaze is helpful because many children with special healthcare needs can recognize their caregiver by looking or hearing their voice. A child may be unable to speak, but the strength and quality in their cry or facial expressions might be a good sign that they need help or they are in distress. For example, a high-pitched cry in a child with a CSF shunt may mean that there is an obstruction.
Work of breathing. Many children with special healthcare needs have respiratory problems. Children with chronic pulmonary diseases, such as bronchopulmonary dysplasia, have rapid respiratory rates and increased work of breathing. When such children have a fever or experience added respiratory illness or injury, such as pneumonia or chest trauma, they are less reserved. Therefore, the work of breathing in these patients increases rapidly with an acute illness or injury.
Assess abnormal breathing, such as stridor, wheezing, or grunting, from across the room. Some abnormal airway sounds may be usual for these children. For example, a child with a tracheostomy tube usually has noisy breathing, and an infant with BPD may have slight respiratory expiratory wheezing. And in the winter, children with BPD or congenital heart disease are more likely to develop respiratory infections, especially from RSV. These children can decompensate very quickly.
Circulation to skin. The skin color may appear different in these children, such as infants with cyanotic congenital heart disease, chronic lung disease, cancer, or liver failure. A child with cyanotic congenital heart disease or chronic lung disease may have bluish lips and mucous membranes, nail beds, and extremities at baseline. A child with cancer may appear pale, whereas the skin of a child with liver disease may appear yellow. Ask a caregiver to describe the child's baseline color.
Airway. Open and maintain the airway. Keeping an open airway may be more difficult with children with special healthcare needs. The child may have poor muscle tone, head control, or copious secretions. The large, protruding tongue may make the airway procedures difficult in children with Down syndrome. Getting and keeping the proper head position may require several attempts or maneuvers. A shoulder roll to correctly position the head into a neutral axis with the airway and chin lift and jaw thrust to the open airway. Always have a suction available.
Many children with spinal bifida have an Arnold-Cherry malformation in which the base of the brain pushes down to the large foramen magnum. Do not hyperextend a child's neck with spinal bifida because any pressure on the herniated brain may cause the child to stop breathing. These children use inline stabilization for an airway maneuver even with no suspected trauma. A child with tracheostomy has an artificial airway easily blocked by secretions or by dislodgement of the device.
Count the respirations, listen to the lung sounds for bilateral air movement, and abnormal chest sounds. Listening may not give accurate results in these children who cannot sit still or have noisy breathing. Also, obtain a pulse ox and compare it to the baseline. Keep the child in a position of comfort. Give supplemental oxygen to any of these children with an increased work of breathing or increased respiratory rate. You can provide oxygen by blow-by, face mask, or BBM. If the caregiver knows the baseline oxygen saturation, only give oxygen to achieve the baseline levels. Children with chronic lung disease or forms of congenital heart disease can get worse if too much oxygen is delivered. The caregiver may know the best way to provide oxygen to the child. For infants or children already on in-home oxygen, increase the flow rate. For a patient with a tracheostomy tube, place the oxygen directly over the tube or stoma. If a child has a history of breathing problems or uses a bronchodilator at home, give nebulized bronchodilator when the patient wheezing is present.
Circulation. Assess heart rate, pulse quality, skin temperature, and capillary refill time. These are not usually different in children with special healthcare needs and require no modification in clinical interpretation. If the child's age is 3 years or younger, you can consider obtaining a blood pressure. However, the value may be hard to get and interpret in this age group. It would be best if you had attempted to measure blood pressure at least once in all children older than 3 years of age. Tachycardia is a common baseline finding in some of the children, and it by itself does not indicate shock. Tachycardia is diagnosis dependent, so asking the child's caregiver about the child's usual heart rate can be helpful. To evaluate heart rate and blood pressure, assess the other key characteristics of circulation. In some children with special healthcare needs, shock management may be no different from for children without disabilities. Standard management includes oxygen, positioning, and bag mask ventilator support as needed. Some of these children may need volume replacement unless the child has a congenital heart defect and possible heart failure. These children have the same fluid requirements as any other child. Suppose the patient is injured. Transport immediately and attempted back vascular access. Give 20 mL per kilogram boluses of crystalloid fluid on the way to the emergency department if the child is ill and has compensated shock. Transport and attempt access and fluid administration on the way. If the child has hypertension or decompensated shock, make one attempt at vascular access if possible. In extreme cases, IO access may be necessary. When a child has a vertical chest scar or a history of congenital heart disease, consider cardiogenic shock to explain poor perfusion. Because these children may be more challenging to assess accurately and because vascular access is often troublesome, always transport a child with suspected shock as soon as possible. Some children with severe, uncontrolled epilepsy may be on the ketogenic diet. This regimen eliminates food with glucose and keeps the child in a state of ketosis to control the seizure. For these children, do not use any fluids containing dextrose.
Many children with special healthcare needs often have a compromised baseline neurogenic status assessor logic. Assess status by looking at the baseline appearance as part of the PAT and establishing a level of consciousness with the alert, verbal, painful, unresponsive, AVPU mnemonic. Compare the findings to the child's baseline. In assessing motor activity, evaluate purposeful movement, symmetrical movement, and movement of extremities, seizures, posturing, or plasticity. Treat altered mental status as if it is a change from normal. The GCS may not be applicable for some of these patients because they have baseline cognitive and physical challenges that would affect this score. It is better to describe what is going on with the child and what is different from the baseline than using a GCS.
Exposure. Be sure to inspect the child's entire body, but respect their modesty. Do not allow the child to become cold. Many of these children have minimal body fat and become hypothermic quickly.
In summary of assessment of children with special healthcare needs, listen carefully to the caregiver when assessing children with special healthcare needs. Ask about the child's baseline status. What is typical for this child? Such children may present with a confusing picture for responders, with unexpected behaviors, communication difficulties, extensive medical histories, and complicated equipment. In addition, the child's neurological status is often compromised. If the caregiver is not present, look for sources to find information about the patient's baseline, such as medical information forms or bracelets. Use standard assessment techniques and developmentally appropriate, modified by baseline comparisons to evaluate and manage acute problems and transport early.